Hello. It is a pleasure to be with you at CIOST 2020, the first one ever to take place online. My name is Dr. Francois Ricard. I am an osteopath and a PhD. I am director of the International Madrid School of Osteopathy, EOM, and president of the Scientifique European Federation of Osteopaths, SEFO. The topic of my presentation will be a new paradigm in cranial osteopathy. There are various principles of cranial osteopathy that have always formed part of our teaching program. Recent scientific studies have showed us which ones are valid, and which do not have any scientific basis, at least for now, and should therefore be abandoned until they have been proven. It is not enough that scientific articles have been published in Pubmed, it is imperative that we assess the quality of the publication, and the research protocol used. The reality is that in many cases, the methodology used is very poor, and provides insufficient grounds to argue in favor of cranial osteopathy. Here is a reminder of Sutherland's cranial concepts. Let us see what the scientific research can tell us. 1. Primary respiratory mechanism. It is an involuntary physiological phenomenon, caused by fluctuations in cerebrospinal fluid, a cyclical tidal rhythm, that is repeated 8 to 12 times a minute, independently from the respiratory and cardiac rhythms, and which can be palpated anywhere on the body. Not been proven scientifically. In fact, various articles have been published showing that this is not a valid concept. 2. Inherent fluctuation of cerebrospinal fluid and cranial rhythmic impulse, CRI. This is a rhythmic, cyclical fluctuation 8 to 12 times per minute of intracranial cerebrospinal fluid, which can be palpated and which is synchronous with the primary respiratory mechanism. Not been proven scientifically. In this Taram sagittal MRI video you can see the circulation of cerebrospinal fluid around the brain. But, watch out! The speed has been increased, it has been sped up to 128 times during a single cardiac cycle, that is to say 128 phases per lub-dub. Algorithm accelerated speed, Stanford University, Auckland University. This very well-known video also shows the movement of the cerebrospinal fluid through the brain. The video on the left has not been amplified and the video on the right has been accelerated. Of course, this image gives the impression that there is a great deal of movement, but watch out. The speed of the video produced by the universities of Stanford and Auckland has been increased using the phase-based algorithm. It is not accurate in real time. I counted the number of pulsations in this video, and it was much higher than 8 to 12 per minute. 3. Inherent mobility of the central nervous system or the internal movements of the brain and spinal cord, caused by contractions of the neuroglial cells. True contractions of the neuroglial cells has been proven in medicine for many years. 4. Reciprocal tension membrane system, which includes the spinal and intracranial dura mater, contains cerebrospinal fluid, and connects the membranes of the cranium and the pelvis. True. Classical anatomy, authors such as Rouvières, Sobota, Netter and Gray have described this perfectly well from an anatomical perspective. 5. The mobility of the cranial bones and sutures. There is a change in the conformation of the sutures and bones of the skull. True, there are multiple studies that have shown intersutural mobility. 6. The cerebrospinal fluid acts as a motor for cranial movements. According to Sutherland, the motor of cranial movements is the force of the fluctuation of cerebrospinal fluid as well as changes in pressure in the intracranial ventricles, caused by the filling and emptying phases and contractions of the brain. Not been proven scientifically, several studies have shown it to be incorrect. 7. The involuntary movement of the sacrum. Between the iliac bones, there is a craniosacral connection. The craniosacral system is established as a synchronous, simultaneous flexion and extension movement of the cranium and the sacrum. Not been proven scientifically. Any study looking for a synchronous relationship between the cranium and the sacrum show that it does not exist. There are several studies showing this. So, what is the basis for a new paradigm? What we want to be true is not always necessarily what is true. What exists is not always what we think our hand is feeling. Which is why it might be time to change the paradigm in cranial osteopathy. New paradigm in cranial osteopathy. The new paradigm could be 1. The PRM or primary respiratory mechanism, described by Sutherland, diffusion of cerebrospinal fluid, appears not to exist. There is no physiological or anatomical evidence to support it. But there is a complex relationship between the different physiological rhythms, cardiac, lymphatic, arterial and respiratory rhythms, as demonstrated by Norton. 2. The cerebrospinal fluid pressure is 0.4 Newton, as measured by hernia. Therefore cerebrospinal fluid cannot be the motor of the system. Furthermore, its displacement, the speed at which it is displaced, is very slow. Hernia, 1999, measured it at 1 cm per hour. The motor of cranial movement is the diaphragm and diaphragmatic breathing via the fascia and muscle system. Nemene's concept, 1990. During diaphragmatic inhalation, the sternum rises, increasing the diameter of the rib cage and reducing the kyphosis and the cervical and lumbar lordosis. The spine increases his length during the diaphragmatic inhalation phase, which corresponds with the cranial and sacral flexion movements. While during exhalation, we see the opposite effect as the spine decreases, and this also reduces tension in the dura mater, which allows the cranium and sacrum to return to their normal positions. 4 main components need to be taken into consideration: blood, which make up brain arterial blood and capillary volume, venous blood, and cerebrospinal fluid. Changes in brain volume are brought about by flow of blood into and out of the brain. This has been demonstrated in various studies carried out by Moskalenko and others. Brain volume is also affected by cardiovascular rhythm, and this explains the pulsations that can be felt on palpation. This is a diagram representing movements of the skull, according to Moskalenko et al. It shows the movements of the bones in the skull, and how they are affected by tension in the reciprocal tension membranes, in relation to breathing, but also by fluctuations in intracranial pressure. The displacement of cerebrospinal fluid, to a small extent, and most of all by regional changes in brain blood volume due to vascular fluctuations. The tone of the brain blood vessels is an important factor, and is associated with the hydration of the brain and its tissue, and the increased volume of neuroglia. This is a very up-to-date explanation of what Sutherland and others have studied. 3. At a craniosacral level, the movement between the pelvis and skull seems to be asynchronous, because of the time needed to displace the sacrum and occiput. 4. The sensation of cranial rhythmic impulse, CRI, is caused by the combination of respiratory and cardiovascular rhythms, and it is not 8 or 12 to 14 per minute. CRI is synchronous with the Traub-Herring-Meyer oscillation, which is a physiological reflex involved in respiratory sinus arrhythmia. It does exist the relationship between the respiratory cycle with heart rate. 5. There is a degree of malleability and elasticity in the bones of the skull. Their shape can change by between 6.49 to 25 microns. The arrangement of the sutures can also vary by between 21 to 41 microns. This is a result of changes to the thixotropy of the extracellular matrix of the bone, which has a viscoelastic quality. This facilitates certain actions in the event of an intraosseous cranial lesion, as described by Magoon, Sergeev, Bikayu and many others. The diagram on right, taken from a study published by Hernieu, shows the deformation of a beveled suture. This was done using the Poisson coefficient of deformation. 6. There are intrasuturales nerve structures that can become irritated because of compression or traction of these sutures. The upper right image is taken from a study carried out by Upledger. It shows the intersutural ligaments under an electron microscope. The red arrows indicate the presence of mechanical captors, used to measure pressure, traction, and nerve fibers that transmit pain. A cranial or suture dysfunction caused by compression or traction will produce central sensitization, irritation of the neurovascular structures and the sensory receptors at the origin of a pathological neurogenic reflex, either from the brainstem, the central gray nuclei, the cranial nerve nuclei, particularly V, 9, 10 and 11, or the upper cervical medulla in C2 and C3. The lower left image shows that the meningeal branches of the trigeminal nerve, which transmit sensitivity, pass through the sutures, and the image makes it easy to see that if this branch is compressed, it will produce pain in a sutural trigger point. Peripheral sensitization is caused by irritation, produced by double crush syndrome, in the cranial nerves, which pass through the cranial foramina, from the first cranial nerve to the 12th cranial nerve. We may also observe sympathetic and parasympathetic neurovegetative sensitization, as well as irritation of the paravascular sympathetic system, which affects the cervicocephalic arteries and venous drainage. The diagram on the right shows how the sympathetic and parasympathetic systems participate in the formation and resorption of bone tissue. 7. We need to change the system we use to diagnose patients in cranial osteopathy, using questioning. Any clinical signs associated with the skull will indicate the areas of the skull that require attention. Examination of the skull will indicate any abnormalities in the shape. Palpating the cranial muscles and sutures that are painful will indicate the bones that are dysfunctioning. An analysis of the elasticity of the bones and sutures using tests such structural buttresses and passive mobility or elasticity tests for the bone fibers, carried out on each bone. The upper figure shows sutural triggers points for the maxilla. The lower figure shows a passive elasticity tests for the bone fibers, carried out on the maxilla bone. Sutural trigger point indicates a dysfunction, which will be accompanied by nerve sensitization. In this example of a case of a craniomandibular disorder, caused by spasms in the masticatory muscles, due to irritation at the level of the sutures in the territory of ophthalmic branch 5 to 1 and maxillar branch 5 to 2 of the trigeminal nerve. The phenomenon of facilitation will maintain a high level of tension in the muscles, producing referred pain to skull and TMJ. 8. The therapeutic actions of cranial osteopathy based on published scientific articles are basically on the cranial sphere. In pediatrics, plagiocephaly, otitis, infantile colic, obstruction of the nasolacrimal duct, orthodontic disorders. In adults, headaches and migraines, craniomandibular disorders, ophthalmology, glaucoma, changes in intraocular pressure, eye muscle imbalances and disorders of the nerves in the eyes, mechanical cervical pain, vertigos, sinusitis, neurological disorders, Parkinson disease, some cases of cerebral palsy, increased saturation of oxygen in the brain tissue, gynecology, modifications in uterine dynamics for women giving birth to facilitate the expulsion of the fetus. Some causes of infertility as studies by Martinez-Loza in 2014. These are all pathologies can be treated using cranial osteopathy, and this has been proven scientifically. These are the true indications of cranial osteopathy in the present day. All other miraculous indications of cranial osteopathy have yet to be proven or properly studied. There is a great need to carry out double-blind randomized controlled trials in cranial osteopathy, using correct, unbiased research protocol. What does this paradigm change in terms of our day-to-day practice in cranial osteopathy? Well, with scientifically accepted theories constructed from valid references, what will change are the explanations that we give, supported by scientific evidence, making the explanations we give for what we are doing much more credible. Realistically, truly little will change in terms of how we carry out our professional duties as osteopaths. The results will be the same despite the fact that perhaps we will have better indications for our treatment that will help to reduce time wasting. Here is a list of all the 78 references, in 8 slides, that were used for this study and for this presentation, put together for this year's CIOST. You can also see here, a list of 6 theses completed at the EOM and presented at the CEPHO, that were used for this presentation. Thank you for listening.